Dear all, it is great honor for me to have such unique opportunity to appeal to you directly through this vain week.
Greetings. It's a real pleasure for me to be asked to present to all of you around the world, wherever you are, about the call to action for Vain Week.
Having a leg wound means never having a good day, but by working together, the Leg Club and Wing Foundation seek to raise global awareness and improve prevention of venous and lymphatic health problems by supporting the International Health Awareness Week. Remember, Vain Week, April. Please come and join us.
Estimados amigos de habla hispana, son las enfermedades venosas altamente frecuentes y subestimadas, y el linfedema una epidemia invalidante y oculta. Ayúdanos a difundir la importancia de estas enfermedades y su necesidad de ser tratadas del 5 al 11 de abril en la Semana de la Vena, Vein Week.
أهلا وسهلا بحضراتكم. من 5 ل 11 أبريل هيكون الأسبوع العالمي للصحة، وكمان هيكون بنقدم الأسبوع العالمي للأوردة. حقيقة الأوردة بتمثل مشكلة كبيرة، خصوصا المضاعفات الدوالي ومضاعفات الجلطات المتكررة التي ممكن أن ينتج عنها القرح الوريدية، ودي بتؤثر جدا في مجتمعاتنا اقتصاديا واجتماعيا. فاحنا بندعوكم للأسبوع الأوردة من 5 ل 11 أبريل. ابقوا معنا. Vain Week.
Goeiedag. 5 tot 11 April merk internasionale aardweek. Ons hoop om bewustheid te skep van diep aardtrombose, bekkenare wat pyn in vrouens veroorsaak, en geswelde bene van die swak erkende toestande van lymfedeem en lipödeem. Ons hoop om julle almal tydens Vain Week te sien.
Halo, saya Dr. Liu daripada Malaysia. Pada 7 hingga 11 April tahun ini, komuniti Phlebotomy akan mengadakan 1 minggu Vena Limfa. Pelbagai aktiviti akan dijalankan. Saya menyuruh kepada semua warga Phlebotomy dan Vascular Society supaya menyertainya dengan bersungguh-sungguh. Terima kasih.
Dal 5 all'11 aprile si festeggia la settimana della salute. È importante però anche celebrare la consapevolezza della patologia venosa e linfatica. Patologia venosa, una delle prime cause di morte prevenibili. Linfedema, un'epidemia definita nascosta, troppo spesso misconosciuta. Quindi vi aspettiamo a braccia aperte per la Vain Week.
प्यारे दोस्तों, आपको पता है कि विश्व में हेल्थ को लेकर हम एक वीक सेलिब्रेट कर रहे हैं 5 से 11 अप्रैल। तो हम चाहते हैं कि उसी दौरान जो नीले रंग की खून की नसें जिनको हम वेन्स बोलते हैं उनकी बीमारियों को, और लिम्फेडिमा जो वाइट रंग की खून की नसें होते हैं उनकी बीमारियों को हम वीक में सेलिब्रेट करें और उनकी नॉलेज बढ़ाएं। बिकॉज वेन्स की बीमारियों से हमारी जो क्वालिटी ऑफ लाइफ है उस पर बहुत फ़र्क पड़ता है। अगर हम इसको एजुकेट करेंगे ड्यूरिंग दिस वीक, ऑल द पब्लिक एंड द डॉक्टर्स, उससे हमारे पेशेंट्स के लिए बहुत बेनिफिट होगा। तो प्लीज़ ऑल ऑफ यू हमारे को ज्वाइन करो वेन वीक 5 to 11 में। थैंक यू।
各位同道们、朋友们，大家好。静脉淋巴疾病是非常普遍的疾病。我们在今年的4月5号到11号会有1周的静脉淋巴活动，谢谢大家踊跃参与。Vain Week， 谢谢。
Un placer invitarlos a participar activamente de este Vain Week 2021. Así que pura vena, pura vida y nos vemos en este Vain Week.
It's April 9, so in Vein Week, it's time to start with a special, or I'd better say multi-special day. We will say welcome, bienvenido, but mainly benvenuti, because this is part of the Italian activities of the Vein Week. As you know, around the world, every single day is dedicated to a different kind of activity. Today, indeed, we focus on multi-specialty here in Italy. And indeed, it was a pleasure for me to organize together with all the Big Win Foundation board this initiative, because it is grouping together the most renowned world experts in the vascular field, but also huge authorities from other specialties. There is a huge, strong Italian representation, including dear academics from the University of Padua. We thank you for joining us today, and mainly dear friends. As I was saying, today we will focus on the multi-specialty approach in venous and lymphatic disease. We will provide a simultaneous translation in English, Spanish, and Italian. Thus, choose your language in the interpretation button. Remember that you can make questions in whatever language in the dedicated question and answer box. We will answer live if possible for time, and if not in a written form in the next days, we will post in a dedicated platform. Why creating a Vein Week? Well, I think the answer is pretty easy, because we have 50% chances of having to deal with the venous disease, whatever kind of patients we are looking at, according to the epidemiology data. Moreover, we are dealing with the leading cause of preventable death if we think about thromboembolism. And I like always to point out the word preventable, meaning that it is our responsibility to increase the awareness of our colleagues and also of the population. Populations that is now hit not just by the pandemic of coronavirus, but also by the hidden epidemic as defined the lymphedema. Not to forget also pelvic venous disorders that have been defined as a forgotten disease that for sure we must not forget about. In life, it's not just where you're going, but it's also who you're traveling with. So we couldn't be more honored and happy in having shared this educational trip with two giants, Professor Caprini and Professor Lee, who have served as ambassadors from the very first beginning of this initiative that is called Vein Week, but for sure it includes also the lymphatics and the approach that must be multi-specialty. We are used to saying we win that players win games and teamwork wins championships. For this, I'd like to deeply thank all the team behind this group effort that indeed started with a steering committee with representations from all around the world and rapidly engaged more than 114 now developers in the different continents, for a total of 271 live events running simultaneously during this week around the world. Nothing would have been possible without the unbiased support of Alpha Sigma, Medi, and Philips. We deeply thank for their biased support once again. Nothing would have been possible without travel mates who have been together from the very beginning, for which I'd like to pass the mic now to Professor Bottini from Argentina. Oscar?
Thank you. Good afternoon, everyone. Once again, we virtually meet in this intense Vein Week, during which we haven't learned so much on this opportunity. I would like to highlight that pathologists and lymphologists, phlebologists and lymphologists deal with problems of many other specialties. They are therefore carrying out multidisciplinary activities with leaders in the fields of orthopedics and gynecologists. Allow us today enrich our knowledge and thus improve our much loved specialty. I hope you will enjoy this scientific meeting.
Thank you so much, Oscar, for what you do. Of course, Vein Week runs during working days, for which we cannot expect everybody to come live, including our scientific director, Professor Chi from the University of California, Davis, who is now indeed in clinical hours. I remind everybody that the webinar will be broadcasted also in recorded forms in the following days. And here is Professor Chi welcoming.
Good morning, good afternoon, good evening. Today we have a great program on thrombosis, risk factors, lymphedema, and pelvic venous disorder. Please enjoy.
And thank you, Willie, for being always so effective and rapid. There is always a special honorary host. In this case, a huge figure from St. Petersburg University, Professor Eugene Shaidakov, who is running outstanding multi-specialty initiatives in Russia, for which here we have his opening remark.
Dear colleagues, dear friends, welcome to Italy VNV, Italy International VNV. We started this program, this very important program, in different countries, in different continents. Yesterday, we started this program in Russia. We name it a round table around phlebology. And many people, different specialties, different professions, from different parts of Russia, different cities took part in this program. And today, we continue this discussion. It's very important to know our knowledge about the venous pathology, the complication of venous pathology. It's a very important program. I started VNV Foundation. Thank you very much for your invitation to take part, to be a part of this program, to be a part of Italy VNV. Enjoy VNV, enjoy discussion, and enjoy the lections. Welcome to VNV.
And we thank Professor Shaidakov for always being a great scientist and also a good sport, as these huge figures who are introducing from the academic world, starting from Professor Mansilla from the Porto University.
Thank you, Sergio, for this so kind invitation to participate in this live educational event on the so important multidisciplinary approach and action on phlebolymphaology. Congratulations for this great initiative of the Vein Week. I would like to welcome all the speakers and the moderators, and to emphasize the huge importance of being all of us together in this approach, involving not only vascular surgeons, angiologists, phlebologists, but also plastic surgery, obstetrics and gynecology, cardiology, physiatry, orthopedics, nutrition, cardiology, and many other disciplines that altogether could bring a better approach, a better team approach for this so important pathology. Thank you.
With this, we fly all the way to Athens University. I see Professor Spiros Pastekis is with us. Spiros, would you like to go live?
Yes, Gianni.
Thank you so much.
Dear Sergio, dear Professor Jean, dear colleagues, it's an honor for me to address this important meeting of so many opinion leaders. The initiative of Vein Week gives us today the opportunity to see experts from different specialities focusing on multidisciplinary actions on specific venous problems. It is certain that we all will learn something new and also will communicate with our colleagues. For me, it's a particular importance, the session of pelvic disorders, and for this I welcome the European Society of Gynecology and the head of this, Professor Tarladzis. Thank you.
Thank you so much, Spiros, and all the Greek friends who are here today. It's my huge pleasure and honor as in Italian to introduce Professor Vitale from the Parma University, huge academic figure in our field.
It's an honor for me to welcome here everybody, and I want to take this occasion to highlight the relevance of venous thrombosis, particularly in these times, difficult times of pandemics. But I also want to take this occasion to stress the problem of lymphedema, a kind of a hidden pandemic, as the WHO tends to define it nowadays, in which physical therapy, and particularly within the physical therapy world, the hydrokinetic therapy can help a lot. And within the hydrokinetic, I want to stress, in the case of lymphedema, the role of balneotherapy, which is a kind of hydrokinetic with thermal spring waters, salty waters, that will deserve a great role, particularly in it's my opinion, in the mild forms of lymphedema, and I believe we will take great advantages in the near future from these physical therapy techniques. So welcome everybody, and thank you for being here.
With this, we deeply thank Professor Vitale. We get started now finally with the scientific part. I'd like just to take a second to congratulate Vein Week Bulgaria, because yesterday indeed we ran a very interesting multidisciplinary sessions on the hot springs of Bulgaria and Italy. Now it's a huge honor for me to introduce one of the three keynote speakers we will have today. Today we will focus on lymphatics, we will focus on thrombosis and on pelvic venous disorders. It's very difficult to find somebody bigger than Professor Roxon from Stanford University for delivering the talk on lymphedema, a hidden multispecialty epidemic. Stan, the mic is yours if you want to share the screen.
Thank you. Thank you so much, Sergio. This is really an honor to be invited to this event. And I will share my screen and begin my comments. Let me go to the slideshow.
Perfect, we can see it.
Always finding the right button to click. Okay, so the topic today is lymphedema as a hidden epidemic, and I'm truly grateful that this is a fact that's being acknowledged. So I'd like to start with some general comments, because before we can talk about lymphedema, we do have to talk about the lymphatic system. And I think there is a potential trap here, given that this is a multi-specialty audience and in general in medicine. If I ask various colleagues to talk about the circulation, of course, I'm a cardiologist, and I and my colleagues will be interested in the pump. We'll be interested in the red portion of this diagram. The audience here is very heavily weighted toward phlebology, and of course everybody in that realm will be interested in the blue side of the equation. But we have to acknowledge that within the circulation, the business end is right in the middle. It's the capillaries. And we also have to acknowledge the most ignored portion of this, which is that for all of that capillary work to occur, we also need the lymphatic conduit, because every time the blood passes through this circuit, it leaves behind 1% of the water content of the blood in the interstitium, and the only way back to the central circulation for that fluid is through this green channel, so-called lymphatic circulation, which is the point of interest today. So again, in order for the tissues to be vibrant and healthy and perform all of their biological functions, they need the microcirculation to be intact. We need oxygen exchange, we need exchange of nutrients, clearance of waste products, and of course we have to keep the interstitium free of excess fluid. We've all traditionally learned about the Starling forces that govern the flux of fluid across the capillary. And of course, this was pioneering work by Starling more than 100 years ago. But we also need to acknowledge that whenever this system doesn't work properly in any of a variety of contexts, we're going to develop edema. And this edema can occur through any one of almost innumerable mechanisms. But you see the important categories here, and they include both hydrostatic and plasma oncotic changes. They can be obstructive within the lymphatics themselves. They can relate to metabolic issues and hormonal issues that lead to sodium retention, and with it, the obligatory water. And of course, edema is a hallmark presentation of inflammation of any sort. I think the key message I would like to deliver this morning, and one that has been evolving over the last decade, is the recognition that while Starling was brilliant, there was one small flaw in his calculations, and that was based on the fact that he assumed that interstitial fluid hydrostatic pressure was effectively zero. And while it is very low, it is not zero. And if one actually makes empiric measurements of interstitial fluid pressure and includes this into the Starling relationship, we see that rather than having a significant component of venous return to the capillary on the venous end of this network, we see that there is net filtration across the length of the capillary, indicating that under normal physiologic circumstances, all return of interstitial fluid is obligatorily through the lymphatic conduit, and this has an important component of the glycocalyx function, which I know Dr. Giannassini is also vitally interested in, as am I. So with this understanding, we see that the lymphatics become extraordinarily important in maintaining the integrity of the interstitial environment and thereby the integrity of most of the tissues, all of the tissues fundamentally within the body. So the lymphatics have several very important global functions. This transit of fluid that we've just discussed, and thereby the maintenance of fluid homeostasis in the gastrointestinal tract. They're also responsible for the absorption of lipid. And one little recognized fact is that, of course, the lymphatics are part of the immune system as well. And it's not an accident that they traverse lymph nodes in their conduit from the tissues back to the heart, which allows them to undertake this function of trafficking of antigen-presenting cells. Very, very important function of the lymphatics. I don't want to belabor this slide except to say that the lymphatics occupy an extraordinary degree of length and a very substantial flow rate, about 25 milliliters per minute. And at any one time, there are about 2 liters of fluid that reside within the lymphatic conduit. Therefore, when lymphedema supervenes, and it can supervene for any of the reasons that were listed on the previous slide as causing edema, we see that there are going to be a very predictable set of physical circumstances that ensue. For the patient population who suffers from lymphedema, the implications for symptomatology and function and well-being are quite clear, and they're quite clearly related to these physical presentations. Who are the population of individuals who get lymphedema? Well, the first issue is that we generally divide this population into those that acquire lymphedema from a putatively normal lymphatic circulation at outset. This can be discussed in further detail, but fundamentally in the developed world, we are talking predominantly about cancer survivors, those that are treated for cancer with either lymph node excision and or radiotherapy, and you can see the relevant common cancers that predispose on this slide. Also, infection is extremely common in the world, and in fact is the most common cause of lymphedema in the world, because lymphatic filariasis represents about 90 million individuals who develop acquired lymphedema. On the primary side, and these numbers reflect the US population, roughly 45,000 patients, this qualifies therefore as a rare disease. This subset, whereas lymphedema in general is quite common, we think that there may be 5 to 10 million Americans, for example, who have lymphedema. Primary lymphedema is presumably based upon an aberration in the genetic blueprint that leads to lymphatic structure or function. The vast predominance of these patients have what has been traditionally called lymphedema precox and represents up to 80% of the total primary lymphedema population. This form of lymphedema has its onset typically at puberty or in young adulthood. A significant proportion have congenital lymphedema, the prototype of which is Milroy's disease, and then a very uncommon presentation is that occurs after the age of 35, represents probably 10% of the primary population. It is the one substrate for which no specific genetic mutation has yet been identified, even though we believe this must be on a genetic or perhaps a multigenic basis. I would commend to you this publication in the Journal of Medical Genetics from last year that represents a very useful and vibrant algorithm for incorporating our growing knowledge into the genetic substrate of primary lymphedema. And if you are posed with the problem of evaluating a patient with lymphedema that is or might be primary, this is a very useful algorithm to go through in order to understand what may comprise the substrate of the problem. I'd like to move on just quickly to the biology of lymphedema. We know that, or I should say, we should know that lymphedema is a form, at least at some point in its natural history, of pitting edema. One finds frequently in textbooks the misapprehension that if it's non-pitting, it's lymphedema, and if it's pitting, it's not lymphedema. That's not correct. All edemas start out as pitting, but in the case of lymphedema, we typically have a rapid progression to a non-pitting component of, or diminishingly pitting, eventually non-pitting, because of the structural changes that occur that are unique to lymphedema, where we eventually get thickening of the skin that resembles the cut edge of a grapefruit. We also see tremendous adipose hypertrophy, which is part of the compelling and largely unsolved biology of chronic lymphedema. We know that the pathophysiology of this condition is quite complex, and where we choose to focus our attention is based in part on our scientific interests, but of course the ultimate solution to lymphedema will involve a better comprehension of all aspects of this very complex pathophysiology. It does become a little bit like the proverbial elephant investigated by the blind man. We're always so blind in medicine and in science, but eventually we have to integrate all of these observations. I want to point out that the lymphatics have really complex roles throughout the body. This preservation of interstitial health is very key to the preservation of health in general, and we under-recognize the importance of the immune component of lymphatic function, and this is lost immediately when the lymphatics malfunction and has a great deal to do with the way these patients present. One aspect of this is the very common problem in phlebolymphedema of cellulitis or soft tissue infection in Europe, often called erysipelas. There was this recent paper in Surgical Oncology in December to show the very important role that infection plays in the utilization of hospitals, at least in the United States, and I'm sure throughout the world, in dealing with these infections. And these numbers are growing with time. So lymphedema often gets swept aside because it doesn't typically contribute in a large degree to mortality, but it contributes very heavily to morbidity and to healthcare expenditure. And we do need to recognize that this immune component of the lymphatics play a very central role in this predisposition to infection. I'd like to summarize all of this by saying that lymphedema is a common problem. It's probably under-enumerated. It has a variety of structural and functional contexts that in turn lead to all of the endpoint events that relate to the disease. And it's very clear that if we take an aggressive therapeutic and preventive approach to this problem, that we will improve overall health. Finally, I'd like to say that the lymphatics actually represent a continuum in health and disease, and we need to focus our attention not just to the vascular manifestations, but to all of the growing list of diseases in which we know the lymphatics contribute either to the pathogenesis, the natural history, or the therapeutics in the approach to the diseases. And the list is growing. Most recently, we've recognized that there is an important component of lymphatic function in the central nervous system, and now we strongly believe that malfunction of this system leads to Alzheimer's disease and other neurodegenerative diseases that have been plaguing human health and which beg a solution, which may be lymphatic in origin. So with that, I will conclude my formal comments, and thanks so much, Sergio, for this wonderful invitation.
It is all of us deeply thanking you, Stan, for always being a guiding light in the lymphatic field. And since this is a multi-specialty day, we thought about organizing the format in this way. Every time there will be a keynote speaker, there will be a keynote discussant. That will be in this case from a parallel, but let's hope these will be intersecting lines. And in this case, it will be from George Washington University, another giant, Professor B.B. Lee. And here is his comment, and then we will have him also live.
Good afternoon, ladies and gentlemen. I would like to thank to the organizing committee to have invited Professor Stan Roxon today to give us such timely, refreshing lecture to redefine lymphedema as a hidden multi-specialty epidemic through this unique opportunity. Indeed, the lymphedema is not a simple static condition of fluid accumulation as a clinical manifestation of mechanical failure of the lymphatic system to transport interstitial fluid out of tissue. Indeed, this old concept is no longer valid. Lymphedema is rather steadily progressing chronic degenerative and inflammatory process of skin and lymphatics and lymph nodes all together through the recurrent episodes of dermatolymphatical lymphoadenitis, so-called DLA, affecting entire surrounding soft tissue with various degrees of fibrotic change. Therefore, new interpretation of chronic lymphedema as disabling and distressing condition to cause physical, psychological, and financial disability should be accepted as a new concept to replace old concepts. I further uphold such a critical finding that not all gene mutation will result in a phenotype due to incomplete penetrance, so that some individuals of the same family can remain as healthy carriers of the genetic mutation and do not develop the full-blown primary lymphedema, but trigger clinically significant lymphatic transport insufficiency later in the life when the triggering conditions are met. This unique group of subclinical presentation merits special consideration in the realm of lymphedema prevention. Thank you.
And with this, we deeply thank Professor Lee. I see is here with us. Bibi, would you like to say another word?
No, that's great. Thank you.
Thank you so much for your special contribution. Now we start with the top experts round. That will be a round from Italy to the world, and also a multi-specialty round, because as you can see, there are different specialties involved. It is my huge honor and pleasure to introduce Professor Franco Bassetto from the University of Padova, the full professor of the plastic surgery over there. A very nice professional, and since we are always focused on evidence-based data, is the perfect person to make a question. I think Franco has a question live, right? Would you like to go live?
Yes, yes. Thank you very much for the outstanding lecture. It's a pleasure for me as plastic surgery to assist to the huge interest that there is all over the world about lymphedema, because in plastic surgery we are trying to improve our knowledge, our surgical knowledge, in trying to propose some new techniques that we are still performing, trying to understand if we can help patients through lymph nodes transplant, through microsurgical procedures, or through lymphovenous lymphatic microsurgery. So, but my question to Professor Roxon were connected with the fact that how do you see the future about to put together new drugs proposal like the use, for example, of growth factor, or using, for example, in surgery, in lymph node transplant, the possibility to have new scaffolds that permits a better survival of the new lymphovenous connection that we can perform with our microscope. This is my clinical main interest in this moment, because I have a very good group of residents that are very enthusiastic to go on with the possibility to develop plastic surgery in the specific field of helping the chronic lymphedema, post-cancer, or even idiopathic. Thank you very much for your question, for your answer.
Thank you. Those are wonderful questions, and I am excited to be able to share what I think, because your questions touch on two areas of my own research investigation. About the drug approach, my earliest attempt to do something to reverse lymphedema, at least in the experimental setting, was in fact with therapeutic lymphangiogenesis. And while it does work in mice, and we were able to show improvement in not only immune traffic, but also reduction of edema and changes in the architecture of the tissues, the problem with induced angiogenesis of any type is that, of course, it's a very multifactorial and spatially and temporally associated phenomenon that is very hard to replicate with any one single intervention of a molecule, even though that molecule may participate physiologically. So I think we have a lot to learn to develop this kind of expertise and skill. And I'm personally not so optimistic that that will end up being the final answer. I think there are other drug therapeutics that are potentially available. And I think that we're learning much more about what are the forces within the diseased tissues that limit the lymphatic regenerative response that allows lymphedema to occur, because in any given risk context, only a small fraction of the total number of patients at risk will actually develop the disease. Somewhat similar to the incomplete penetrance that Professor Lee referred to in genetics. If you take a breast cancer population of survivors, only 15 or 20% of similarly at-risk individuals will develop the disease, and it probably is on the basis of an impaired regenerative response in those individuals. In my own work, we found that specific inflammatory mediators that are involved in the pathogenesis of lymphedema actually block the regenerative response. I've been particularly interested in leukotriene B4, and we have shown that both in the human and in experimental contexts, antagonizing LTB4 actually allows lymphatic regeneration to resume and to reverse the lymphedema. So I'm very optimistic about that approach. Your final question was about the surgical techniques, and I've also had some interest there. I think one of the beauties of vascularized lymph node transfer as an approach to this problem is it does help to directly restore the immune function in the limb, which may be even more important than the interstitial fluid maintenance. And one of the and I share your interest in the whole notion of surgical scaffolds, because what we know from animal models is that what is key to the success of vascularized lymph node transfer is the timely integration of the transplanted lymphoid tissue into the surrounding lymphatic circulation. And if that is delayed, and it is a lymphatic regenerative process as well, then the lymph tissue will not survive and the function will not resume. So these biological scaffolds actually accelerate the ability of the transplanted lymphoid tissue to incorporate into the surrounding matrix. And we have done some work in this regard with nano-aligned collagen fibril-based scaffolds that do show evidence of being very successful in large animal models. So maybe I'll stop there. I hope
Yes.
that has addressed your question.
Sorry, but it is a wonderful opportunity to promote the, I think, 800 years of the University of Padova, Cradle of Medicine, for next year. So where I hope we will have the chance to be again in person and have a fruitful discussion on this very interesting question that is worthy of our webinar. Thank you so much, Professor Bassetto, and thank you so much, Stan. We move forward. We stay in Italy with Dr. Corda. Question to you.
Dear Stanley, I'm so sorry for the impossibility to be in presence. I thank you for your presentation, a clear, synthetic, and very complete presentation. You have described as lymphedema is a chronic and incurable disease. You underlined prevalence that is increasing. You showed us its natural history and its pathophysiology. And thanking to the work of the researchers and the scientists like you, we know lymphedema today better than yesterday. I think that at the moment, to save the costs for the therapy of the disease, and above all, for the therapy of its complication, we have to fight for the prevention as soon as possible and as better as possible. Thank you.
Stan, do you have a comment on this?
Absolutely. First of all, Domenico, it's wonderful to see you, even recorded, old friend. I absolutely concur. Prevention in any aspect of medicine is better than treatment. And we fortunately have developed some skills now where we can perform surveillance of these at-risk populations and intervene early and sometimes, in fact, reverse the otherwise inevitable path toward the development of lymphedema, which then becomes a progressive and very difficult to control problem. So we at Stanford utilize bioimpedance spectroscopy, and we aggressively perform surveillance in the cancer survivor population during the index first year after their cancer therapy. So Dr. Corda, I'm in absolute agreement. We need to prevent this disease wherever possible.
Thank you so much. Now we fly all the way to US, and since it's always teamwork, we like to take this chance to welcome Professor Lorena Grillo, who is contemporaneously running a webinar in Costa Rica where we are broadcasting now. So Lorena, if you'd like to introduce the next top expert.
It's an honor for me to greet you all and also to introduce Diane Neuhardt, who is a top expert and a top quality person. Diane?
And here is her message that will be a quite easy comment for you, Stan.
Sergio, in reviewing Dr. Roxon's presentation, I'm just humbled and in awe of the knowledge and so much to share among colleagues. I really appreciate Dr. Roxon, and I'm very honored to be on the panel just in his presence. Thank you.
Now, this is quite easy, but I have a surprise for you because I like to take this opportunity to make a question to you, if possible. So noticing the endothelitis we have with COVID and understanding, of course, the endothelium has similarities in the veins and lymphatics, I wasn't able to really find papers describing this phenomenon on the lymphatics. Apart one in 2020 showing a potential interest of the brain lymphatics. Would you have some comments and some clinical suggestions for our lymphedema patients in COVID time? Is there any issue with this or not?
Thank you, Sergio. So ironically enough, I was asked to give a talk on this topic at the American Venous Forum just a couple of weeks ago. And I did as much in, research as I could in the literature, and not surprisingly, there isn't much on lymphatics. What is interesting is that many of the molecular attributes of the endothelium that are called into play in the other portions of the circulation are not present to a very high degree in the lymphatics. And as we all know, the ACE2 receptor is very important in the virus interaction. And there is a group that has done an atlas mapping of expression of all of the cell types in the lung, for example. And we find that in the lymphatic endothelium, ACE2 is expressed to a very minimal degree. So it's not entirely clear the extent to which the lymphatics are responsible for the propagation of the disease. There is some evidence that neuroinvasion may have a lymphatic mechanism, and that, of course, is an important substrate of the disease. But in general, we can presume that the lymphatics play a role in the barrier to the disease and to the coping with the disease once infection occurs. As far as the implications for the lymphatic population, most of the national and international societies have promoted the idea that immunization is safe and appropriate, and when feasible, the upper extremity should and could be used, but in the case of bilateral upper extremity lymphedema, one can also administer the vaccine in the lower extremity. One should bear in mind that the lymphatics are already compromised regionally in a patient with lymphedema, if not systemically in some of the conditions. And with the inflammatory burden of the immune response, we're going to potentially see transient worsening of the lymphedema presentation as the lymphatics have to participate in the processing of the vaccine. But this should not be an impediment to using vaccination aggressively in this patient population. Those that are immunocompromised, who have broad lymphatic structural or functional abnormalities, may not be good candidates for immunization, and of course are at vastly increased risk for infection with the virus itself.
Extremely interesting. Thank you so much, Stan. Now, it's a huge pleasure for us to present the next top experts, and it will be Professor Bottini, because we're used to say that oceans are separating regions, not people, not friends, in this case, not even family members, because we are used to our dear Professor Shoaib Padaria. But today there is an exception, Oscar, because we will introduce now.
Yes, let me introduce Rafat Padaria, a top cardiologist from USA, but also sister of our dear Shoaib, Sergio. Rafat.
And here is the question of Rafat for Stan.
Good morning. Thank you for having me on this forum. I'm one of the cardiologists here at Cardiovascular Medicine, and I practice in Davenport, Iowa. I see a lot of lymphedema patients, and unfortunately, this diagnosis is not very easy to make. I really appreciate the talk. It was very informative. I do have a question for you, Dr. Roxanne. What do you think is the best diagnostic modality to use to help us diagnose this effectively and help us with therapeutic options? What do you think are the latest newer diagnostic modalities, knowing that you're very involved in lymphatic research? And if I may, another question would be, do you anticipate some standardized guidelines about diagnosis and management of this condition, which unfortunately has not really made it to the big scene in management globally? Thank you so much for your input.
And we thank you, Rafat. Stan, last question for you.
Those are wonderful questions. So let me address the first part, which is diagnostics. I will say that we have been interested very much in biomarkers for this disease and have published a couple of observations that seem to be valid in human lymphedema. They're not ripe yet for clinical use, but I'm hoping that they will be useful both to identify disease substrate and preliminary stage 0 disease, as well as perhaps guiding therapeutic interventions and responses. I think the bulk of lymphedema diagnosis resides in the clinical consultation room. I think well-trained clinicians should be able to, with some accuracy, detect even mild forms of lymphedema. But of course, we then rely upon imaging techniques. I think for the ascertainment of the diagnosis, we can still consider the gold standard to be radionuclide lymphoscintigraphy. The problem with this imaging modality is it's a functional imaging modality. It doesn't tell us much about anatomy, and it has variable sensitivity and specificity. If we really want high specificity, then I think the evolving gold standard is really magnetic resonance lymphography, which can either be non-contrast enhanced with heavily T2 weighted imaging to image the water content of the lymph. And this is very useful in the peripheral vasculature. For central vasculature, we do rely upon the use of gadolinium, either injected into the subcutaneous tissues a la standard contrast lymphography or directly through ultrasound imaging into lymph nodes. I also think that this latter technology is very useful for any kind of surgical planning and for dealing with patients who have central lymphatic disorders. And in addition, and the final one I will mention, for the plastic surgical colleagues, it is very useful now to utilize near-infrared lymphography. Typically, we use ICG as the contrast agent, which has biological fluorescence under near-infrared light. It has limitations in that the penetration is quite poor. One has to only see the lymphatics that are very close to the skin because of the infrared component, but is very useful in ascertaining where the lymphatic channels are when thinking about lymphaticovenous anastomosis or perhaps the potential of vascularized lymph node transfer.
Thank you so much, Stan, for answers that were as spectacular as the keynote speaker talk. Now, because of time, I will ask you if you have a second to reply in written form to Dr. Mohammad Rahman, who is writing his question in the question and answer box, so we can move forward. And of course, we will see you soon at the first opportunity online, hopefully soon in person. Thank you so much again, and super congratulations. And now, another giant, our Professor Caprini, really a guiding light for all of us every day, I would say, considering the importance of the thrombotic risk assessment. And indeed, the topic is facts all specialists should know about the risk assessment. Joe, knowing you, I guess you want to go live sharing your screen, or if not, we have the presentation ready. You go live, okay. We cannot hear you though. You're mute. Unmute yourself. We can see the slides, but you're mute.
Okay.
Yeah, now we can. Perfect.
Thank you very much indeed, Professor Gianzini. It's a great honor to be a part of this, and it's an incredible chore to follow that brilliant presentation by Dr. Roxon, including all of those brilliant comments. I learned an incredible amount about lymphedema this morning, and it is really indeed an honor. I would like to talk about us remembering one thing here. There's oftentimes people try to use shortcuts. They look at individual a few factors and so forth. We are dealing with the #1 preventable cause of death after surgery. How many diseases or how many conditions after surgery can you prevent? I mean, anastomotic leaks, bleeding, the need to reoperate. A lot of things are beyond your control, infection especially, but not venous thromboembolic deaths. They can be prevented by using appropriate prophylaxis. Unfortunately, we see that the PE mortality has increased over the past decade, and we're not going in the right direction. Now, I would like to start out by talking about a good history in physical. It's almost an impediment that my name is associated with this, because the goal is not to talk about Caprini, it's to talk about doing a thorough history and physical on your patient. And that's really important. Why? We know as the number of risk factors goes up, the incidence of venous thromboembolism goes up. We know that these risk factors are of different powers. Some are very low risk, and such as bed rest, and others are very high risk, such as carcinoma of the pancreas. Taking the variability and the synergism of the power of the risk factors and the number of the risk factors, we come up with a score, and the score shows a nonlinear increase in the rate of VTE. So as the score goes up, the incidence of VTE goes up. And this has been shown in over 5 million patients in 210 studies as of the present time. Here we see it in general surgery. There's really, there's 4 important elements here, which I'd like to stress. And I have videos on this on my YouTube site, or any of you that writes to me, I will send them to you. First of all, the set points for high and highest risk are different for different populations. Here in general surgery, 8 and above 8 is high risk. In orthopedics, it's 10. But turning that around, if you're in head and neck surgery, a score of 5 is almost associated with no clots. And so that's a very important thing, that you have to look at the set point in individual populations. The guidelines have not helped us. In 2012, CHEST finally acknowledged that we should be doing risk assessment and said that the Caprini score was one system to use, and if the score was over 5, there was a 6% chance of getting a blood clot. Well, that was based on 3 papers in 2012. We have over 200 papers now. That's no longer true. And I was shocked to see in the 2019 guidelines, they didn't include one, not even one of those. At the time, it was 150 papers, but there was a very important meta-analysis there that was really key, that was also omitted. So the practicing physician has nowhere to go with that. And so please look at my video on that. The other thing are the descriptors. What is meant by each of the risk factors? Do all of you realize that we have a very good definition for ambulation? And it comes from a paper done in 2000, the year 2000, which was a sub-analysis of the Metanox trial. And it's been largely ignored. And so there are important things that one has to look at. And this is a very, very complex subject, but it's worth taking a look at. Now, one of the downsides of collecting a good history in physical is that if somebody comes in with a stroke, if somebody comes in seriously ill with COVID-19 or an auto accident, nobody's going to ask you 40 questions on whether your grandmother had a pulmonary embolus. It's just not going to happen, as important as that might be. So I have advocated, along with a lot of my colleagues, a secret weapon: the patient. Patients love to get involved in their care. So we've involved the patients in their care by thanks to the presence of brilliant investigators from around the world. A patient-friendly risk assessment form has been validated in multiple languages. And I'm just showing you the score here. And there's something else about this score that's absolutely critical in my view, and has been ignored. And I'm glad we have some gynecology representation today on this webinar, because patients who experience obstetrical complications, stillborns, multiple unplanned abortions, toxemia of pregnancy with a growth-restricted infant, a baby born smaller than appropriate birth weight. These all are clinical clues to the antiphospholipid antibody syndrome, which a patient may carry for the rest of their life, even way after the obstetrical incidents. And we track that in this risk assessment. And the importance of doing it with your family is that you can discuss these problems. Now, the second thing is about this risk assessment score, which is unique to this score and only one other, as far as I know, and that is a family history of thrombosis. And there was a Scandinavian study of 183,000 patients in over a 25-year period with matched controls that show that all 3 degrees of family lineage are important in terms of predicting venous thrombosis. So if you have a patient that doesn't have a venous thrombosis, but has a strong family history, that may make the difference between life and death, because often that is not looked at. And I would say that, just to go back 1 minute, that the British Health risk assessment, although it's brief and I don't think it has a lot of things in it that I'd like to see, but that health assessment, when applied over a 2-year period in the United Kingdom, first of all, it tracks family history of thrombosis. And the other thing is it tracks, it has shown the decrease in death rate. Now, I'm also astonished that 2 of the scores, including PADOA and improved D-dimer, they're very useful scores that have been used around the world. Why is thrombophilia listed? And one of my friends says, oh, well, that's because nobody, that's one thing less they have to check off. We don't look for thrombophilia markers most of the time in the United States, and in Asia and in other countries. That's not something that's done. It's not necessary in many places. And also 90% of people that have thrombosis will not have a positive marker. So that doesn't really help us. So family history is what's really important there. And the British system has also documented that. Now I'd like to present the poster child for the United States benchmark for the nation. And that's a Caprini success story requiring mandatory and standardized risk assessment, using also something else that I would like you to go and look at, and I didn't mention that. It's called the Grim Reaper, and it's a video that I have on YouTube. And the Grim Reaper, of course, is fatal pulmonary embolism. And I will show that over the history with the KCARs and Collins meta-analysis and 51 additional trials that published in Chest, the length of prophylaxis is 7 to 10 days. It's not 1 to 2 days. And that's been totally ignored. And it's one of the reasons why the incidence of thrombosis in many cases is not going down. Well, here we have this benchmark, and it's composed of dividing people into low, moderate, high, and highest risk. Those patients with a score of less than 5, it's optional what you do during hospitalization. And now you can even take the low molecular weight heparin out of the equation if you want, because it's not mandated. It used to be, patients come in for 1 or 2 days, and the Surgical Care Improvement Project would say that you had to give a dose of anticoagulants within 24 hours. And then they go home the next day and nothing more is given. Well, that doesn't make any sense. Now, what's important about this benchmark is that if the score is 5 to 8, people had to get 7 to 10 days of low molecular weight heparin injections. Didn't make any difference where they were, if they went home or they didn't. And if the score was 9 or more, they had to get 30 days of injections. You can see 89% and 77% compliance, respectively. And here's what happened. They had a high incidence of VTE at 30 days. The green line here is the national average, and they reduced that down to a less than 0.5%, 84% risk reduction using this program. Now you might say, well, that's all well and good, but this is probably some high rent district hospital in Boston. No, this is an indigent hospital. And the administrators made a deal with the insurance companies and the drug manufacturers that any patient who needed this prophylaxis would get it regardless of their ability to pay. And that's what this is all about. And that's why this was a benchmark of the nation. What do you think would happen if every hospital were able to show these figures by doing this? And one thing I would like to point out that's important is it has to be mandated. You have to mandate the algorithm, and doctors have to agree to it before they sign their orders. They can always opt out, of course, if there's an individual region. But most of the time, if you don't mandate it, this won't happen. Now, here is a study that everybody needs to get out and reread, because this is the study, among a lot of others that love data, that this was a study that was done between heparin and low molecular weight heparin by a low molecular weight heparin company trying to show that their drug was better than unfractionated heparin for what? For the Grim Reaper, for fatal pulmonary embolism. The endpoint of the trial was autopsy adjudicated fatal pulmonary embolism. And you'll notice if the patients got either heparin or low molecular weight heparin, their incidence of fatal pulmonary emboli autopsy-wise was 0.1%. Now, I won't say it's always that in all studies, but it certainly shows that this is why I say that you can prevent most deaths by using low molecular weight heparin. And also a death from anticoagulant prophylaxis is a medical curiosity from a prophylactic dose. Now, was there bleeding in this series? Of course there was bleeding in this series, but nobody died. But think of the people that would die if they weren't given anticoagulation. Now, how does a surgeon prevent these fatal events? Through thorough assessment of the patient's risk, appropriate use of anticoagulant prophylaxis for the entire period of thrombotic risk. And remember, this is another problem that's not been addressed properly. I've had patients that come in and they had a low Caprini score when they were admitted, but during the course of their hospitalization, they had an operation, infection was found, or cancer, or they leaked, or they had to be reoperated. They needed IV antibiotics. They got central lines. They developed pneumonia. Well, you've got to add all of those factors in. And at the end of the day, before the patient goes home, you have to do a final tally to see whether or not it's important to give them prophylaxis after they go home from the hospital. So most patients require 7 to 10 days of anticoagulant prophylaxis. Very high-risk patients benefit from 14 to 28 days of anticoagulant prophylaxis. And if every hospital followed this Boston model, the fatal PE rate would be very low. And I know time is short, and I was just so delighted to see my dear friend Case Wittens as a part of this today. And he asked us about the direct oral anticoagulants. And we'll get to that in a moment. Of course, you can use the direct oral anticoagulants. They work very, very well, but I'll come back to that. What I want to do is point out something else, because we have the orthopedist with us today. Some patients remain at risk for longer periods and require continued anticoagulation prophylaxis. Now, let's take a look at the trifecta, which I would call a recipe for disaster. We know that Virchow's triad of venous stasis, endothelial damage, and hypercoagulability, all of those three factors, when they're together, cause a are likely to result in a venous blood clot. Well, what about the trifecta of an immobilized non-weight-bearing patient with a straight leg brace on? First of all, I can show you data that if the patient isn't weight-bearing, there's no increase in blood flow in that leg. That's the first element. The second element is the arteries are still pumping blood into the leg. They're overfilling the veins get distended, and we have some beautiful pictures from Tony Camerata showing those cracks in the endothelium. Clots form in those cracks. So that's the second thing. The third thing is the metabolites are, the tissues aren't dead. They're still producing metabolites that are gathering in this static pool, this witch's brew, and therefore that can also lead to the third limb of Virchow's triad. So you've got stasis, immobilization, and vascular damage all sitting in the immobilized limb. And then if you put that patient in a brace that's in full extension, some of the patients, and Diana Newhart taught me this, and I know she was on the call, that she showed us this, that if you straight leg go into straight leg, put the leg in extension, total extension, the gastroc muscle will often cross in front of the popliteal vein and obstruct it, the popliteal venous obstruction. And that's why people, when they're standing a guard, are advised not to have their legs in full extension, because they could faint if they suffer from this. And not everybody has popliteal entrapment. But now we'll take a look here. Look at this trifecta. This has been totally ignored. But these patients need prophylaxis until they're no longer immobile, till their ankle pump can work so that the calf can pump, and the extension has been relieved. So these individuals are extremely prone. And so the next thing I want to get to is, do you need a clinical trial to prove all of this together in a large randomized trial? Give me a break. If you jump out of a plane, do you think that you need a randomized trial to prove that, to establish the value of using a parachute? Of course you don't. So one may argue that clinical experience and judgment may be useful to prevent pulmonary emboli in high-risk individuals. As we go through practice, we encounter all these situations, and we develop what common sense and what we need to do. So Case is asking us about the DOACs. The DOACs have been a fabulous success. They don't require anticoagulant monitoring, number one. Number two is that if something happens, they go away quickly. Number three is they've shown to be very effective in a whole host of conditions. Of course, you could use the DOACs. And I will address specific comments a little bit more about it later, but that's a good example of clinical judgment. And whatever your country has, whatever is available to you, and whatever you can use to prevent the Grim Reaper, you should do it. So I would like to conclude by talking about never killing a friend and never treating a stranger. Performing a thorough history and physical gives you knowledge about your patient as if they were a good friend. And of course, you would never kill a friend, and you would never treat a stranger. Thank you very much. Please go to my YouTube platforms or all my social media platforms for more information. And I encourage you all, jcaprini2 at AOL. Send me your questions. I will send you all the videos you want. I will be happy to entertain. In fact, I love to get constructive criticism, because, as I say, I've been singing this song so long, I believe it, but now I need input from people around the world. Thank you very much for your attention.
Thanks to you, Joe. Talking about singing, it was like listening to John Lennon, so wonderful. So now, a very special moment for us, quite an historical moment for our group, because we have the huge honor of having as expert discussant of the keynote a huge figure from the orthopedics world, the president of the International Society of Orthopedics and Trauma, so the World Society of Orthopedics. And here is his perspective on your talk, Joe.
Greetings, everyone. I represent the orthopedic surgeons of the world, and I represent specifically CCOT, which is the International Society for Orthopedic Surgery and Traumatology. I'm very, very happy to be here, and on this occasion, I would want to talk to you about the orthopedic perspective to venous thromboembolism. Well, CCOT, as I mentioned, is an orthopedic body and it was founded in 1929. It's the oldest International Society of Orthopedic Surgery. I must start by congratulating the organizers of the Vein Week for this splendid initiative to create awareness and share knowledge on this devastating disorder that commonly affects hospitalized patients. The International Society of Orthopedic Surgery and Traumatology is happy to be involved. I'm happy to share the stage with Professor Caprini, an international giant in this field. Now, importance of venous thromboembolism is that it is a preventable cause of death in hospitalized patients. The overall incidence ranges up to 40 to 60% in major orthopedic surgery. Without any prophylaxis, pulmonary embolism is responsible for 5% to 10% of deaths in hospitalized patients. However, with routine prophylaxis, fatal pulmonary embolism is uncommon in orthopedic patients. The incidence of fatal pulmonary embolism is 2% to 3% after elective hip replacement and 4% to 7% after hip fracture surgery. The risk factors have been enumerated so well by Professor Caprini, and this whole scoring system is based on risk factors. Now, strong risk factors for venous thromboembolism include a fracture of the pelvis, hip or leg, hip or knee replacement surgery, major trauma, and spinal cord injury. All these are scored 5 each on the Caprini score. Important also is to note the fact that hypercoagulability can persist for 6 weeks after a hip fracture, while venous function remains significantly impaired for up to 42 days following hip fracture surgery. And this gives rise to late thromboembolism. And the importance of the risk factor in covering patients who have a high risk for VTE. So we look forward to synergy, we look forward to collaboration, more sharing, and hence caring for people all over the world with this wonderful initiative. I would want to thank the Vein Week team and our best wishes from the International Society of Orthopedic Surgery and Traumatology to the Vein Week. Thank you for the invitation and thank you for listening to me.
We deeply thank indeed Professor Ashok for this first step of what I hope will be a long road together. Adesso devo passare all'italiano. Passerò all'italiano perché introduciamo una grande figura italiana che è il professor Avruscio, sempre dell'Università di Padova, dedicato in particolar modo all'angiologia. Avremo quindi il round delle diverse specialità.
I miei complimenti a Sergio Genesini, a tutto il comitato scientifico, il mio saluto a tutti i partecipanti e il mio ringraziamento al professor Caprini per la sua sintetica ed esaustiva relazione. La tromboembolia polmonare è aumentata negli ultimi anni, sicuramente per l'aumento della sopravvivenza e degli interventi chirurgici sempre più possibili in età avanzata. E grazie soprattutto per aver messo in evidenza in un periodo di avanzata tecnologia della medicina quanto sia importante l'approccio clinico al paziente, sia nel calcolare il rischio trombotico che il rischio emorragico. La terapia anticoagulante, quando indicata, viene somministrata a dosi ben precise, standardizzate a seconda del peso del paziente. Generalmente non è così per la profilassi. La clinica non dovrebbe forse tenere conto che una stessa dose di profilassi somministrata a un paziente di 60 kg potrebbe essere non efficace per un paziente di peso maggiore. Esistono studi randomizzati in questo senso. Inoltre, con l'avvento di una diagnostica sempre più avanzata, i rischi legati ad una possibile trombosi distale sottopoplitea equivalgono a quelli di una trombosi prossimale, ovvero se troviamo una trombosi venosa sottopoplitea, meglio la profilassi o considerarla come una trombosi prossimale e somministrare dosi terapeutiche. Grazie ancora per questo invito in una importante e fondamentale discussione e saluto tutti con l'augurio di incontrarci di persona, citando un verso della Divina Commedia di Dante Alighieri che compie 700 anni, poter dire dopo l'inferno di questa pandemia che quindi uscimmo a rivedere le stelle.
Gio, hai un commento su queste domande del professore Vruscia?
Yes, thank you very much indeed for that very, very important question. And I think that this is another astonishing thing in my mind. Patients who develop thrombosis are in a special category to those that don't. Some of them develop thrombosis below the knee. Does that mean we ignore it because most of the time that's not a problem? I think that's ridiculous. I think that if a patient develops a clot, that labels them as a clotter. And if you don't protect them, there's always a chance that that clot can grow and cause a problem. Or the next time they have surgery, what was originally a small amount of damage, then the next time they get the big one. So I really think it's important to prevent clots. Now, you always have to, and you also mentioned in your discussion, the balance between the risk of bleeding and the risk of thrombosis. So I think that's a very important thing to keep in mind. And one thing I want to say is if you think the patient is initially at high risk of thrombosis, then you wait a day or two and then maybe you can start the prophylaxis. But don't forget about calf vein thrombi.
Good. Bene. Devo ancora parlare in italiano perché abbiamo un altro video in italiano, Joe, da parte del professor Stefano Masiero, un'altra figura importantissima del mondo accademico italiano, in questo caso dalla fisiatria dell'Università di Padova.
Buongiorno, sono il professor Stefano Masiero, direttore dell'unità operativa di riabilitazione ortopedica e direttore della scuola di specializzazione in medicina fisica e riabilitativa dell'Università di Studi di Padova. Ringrazio il professor Sergio Gianesini per l'opportunità riservatami e ringrazio il professor Caprini per aver fatto luce sulla problematica del rischio tromboembolico e la relativa profilassi. La profilassi antitromboembolica è una realtà con rilevante impatto sulla presa in cura del paziente post-chirurgico e non. Il contributo del Caprini Score alla valutazione del rischio tromboembolico del paziente integra ed estende le risorse di prevenzione disponibili. Nella mia unità operativa effettuiamo approfondimenti per la valutazione del rischio dello stato ematico e venoso mediante esami ematochimici, ecocolor Doppler e valutazione angiologica grazie a una intensa collaborazione con i servizi di radiologia ed angiologia. Uno dei problemi più sentiti delle realtà riabilitative è l'indicazione alla mobilizzazione precoce del paziente acuto e del paziente con diagnosi di trombosi venosa profonda per l'impatto nel recupero di funzione e tempi di degenza. Al professor Caprini vorrei chiedere un ulteriore approfondimento sulle indicazioni alla mobilizzazione precoce dei pazienti con Caprini score maggiore di 0. Grazie.
Joe, un commento? Do you have a comment, Joe, on this?
Yeah, well, I would just like to make a comment on ambulation. Everybody needs to read Al Peshameen's paper published in 2000, the sub-analysis of the Menonox trial. In the Menonox trial, they defined people who could walk 30 feet and those that couldn't. If they could walk 30 feet and they didn't get anticoagulants, their risk of VTE was cut 50%. If they were in the low molecular weight heparin group, their risk was cut 66% from 9% to 3%. So it's very important that we talk about ambulation and, you know, these evidence-based guidelines like coming out from the ASH, they talk about people who are at bed rest. Well, if you get up and go to the bathroom and walk 2 feet and sit in a chair, you're still at bed rest. That's one problem. The other problem is that if you get up and then they tell you, oh, we won't give you this painful shot as long as you get up and walk around. That's nonsense, because ambulation is only one factor. And if you've got cancer, history of thrombosis, inflammatory bowel disease, and so forth, you're still at very high risk. So I'm not sure that I actually understood that question, except to say that we need to ambulate people early and often. But I want you to all really figure out that we do have a scientific definition of ambulation.
Thank you, Joe. Now we fly on the way to India, thanking once again Rafat and thanking also Professor Lorena Grillo, who will introduce another Padaria.
It's a pleasure to introduce Dr. Shaib Padaria, who is another prominent professional from the Venous Association of India. And we had greatly enjoyed last time in Italy at Winter Cortina. Dr. Padaria.
Good evening, all my Flebo friends from all over the world. Sergio, thank you for the opportunity. Professor Caprini, I have had the honor of listening to you so many times earlier. And once again today, your presentation, as usual, is simple, lucid, and to the point, comes across so clearly. I agree with you entirely about the point that you made about a very good history and physical examination in eliciting the probable risk factors in a patient. In our country, which is a developing country, it's difficult to do all the tests. It's financially very difficult. And a good history and physical goes a long way in identifying a large number of patients who would probably develop VTE. That's number one. Secondly, as a cardiologist, we have a significant number of patients of congestive heart failure who are at full bed rest with multiple comorbid risk factors such as diabetes, hypertension, obesity. And these persons are often at bed rest for long periods of time and at significant risk for pulmonary embolism. I take your point that prolonged anticoagulation is necessary. Due to logistic and financial reasons, we can't continue with low molecular heparin, but we do give direct oral anticoagulants. What are your thoughts if a patient is compromised and at bed rest with all these risk factors, with a low ejection fraction? How long do we give these patients prophylactic anticoagulants?
Thank you very much. I can't believe that it's been 11 years since I did a wonderful tour of India and met so many wonderful people in that country. And one thing I always told them was that you people are so smart, I wouldn't possibly be able to answer all your questions. But this one I think I can do okay. First of all, you're absolutely right. There's three things here. You're absolutely critically right about the history and physical. The only reason that I even have any thrombophilia markers in that original list is in case they were done. They don't need to be done. It's not necessary to do those. Family history is most important. The second thing that's important is that those patients with congestive failure, even if they have normal ejection fractions, they still have are at very high risk for thrombosis. So they need to be protected until they are fully until they're ambulatory and until their acute episode is over. And as far as the direct oral anticoagulants, and we have they're great drugs, and they've been very well used. And that's a golden opportunity to use the direct oral anticoagulants. And one has to remember that a prophylactic dose of one of those oral anticoagulants, you're not going to die from that. Plus, they're very short acting, and they'll go away if something happens, if there's some bleeding. And that's why it's even better than for example, Coumadin and even low molecular weight heparin. I stress low molecular weight heparin because that's where the evidence is. But by God, if you can use an oral anticoagulant, you really ought to do it. And I'll make a couple more comments after we hear from Case.
That is great, because indeed we are short in time, and it's my pleasure to pass the mic to Professor Bottini to fly all the way to Netherlands to present another huge expert.
Thank you, Sergio. Now it's time for me to present Professor Wittens, leading figure from the European College of Phlebology. Dr. Wittens, are you ready?
Unmute yourself.
Yes, well, thank you, Sergio, for having me in again, and it's a pleasure to join. But coming back to the talk of Joe, well, I think after having heard you talk so many times, you really miss your profession. You should have been a preacher, and you can talk anybody in any belief, in any religion. It doesn't matter. Everybody will step in anytime. So you convinced me too. And so I'm not doubting anything of you. And I think in Holland, we have the possibility to have everybody on an iPad filling in their questionnaires before they come into the outpatient clinic. So the risk assessment you are presenting is easy. You can get the number before the patient even gets into your outpatient clinic. So that's no problem. But I think, and that's what I asked already, I sent a video for in case I wouldn't be there. But I'm a little bit curious for what's your opinion about using DOACs. You mentioned it several times, and I hope that you at least conclude that this is the way to go, because that's easy, because to have it for 7 days organized in older patients, to have them low molecular weight heparin administered, that's a difficulty. And oral anticoagulation, the DOACs, is much easier. So I'd just like to know your opinion on this. And thank you very much for getting me into a new religion again.
Yeah, thank you, Case. I'm deeply honored by your comments. And I believe that that's true. Not only is low molecular weight heparin could be a problem, but it can be expensive. People don't like to give themselves shots. And the oral anticoagulants are a perfect situation. And I think you have to divide people into several camps. The first camp is if you think the patient preference for prophylactic doses, they all work very well. And if a patient just will be more compliant with a once-a-day dose, mazel tov, give them rivaroxaban. If they decide that they want to go for, twice a day, then use Eliquis. And what I would like to say about these two drugs is that for gastrointestinal surgery, and there's a little bit higher propensity for rivaroxaban to be associated with some gastrointestinal bleeding. So that might lean me a little in the direction of apixaban in that case, but not necessarily. I think both are good choices. And if you can get a patient to take either one of those drugs for 10 days or more, that's really a benefit. Dabigatran is another choice. And we have to figure that in. Now, dabigatran's a little different because it takes a longer time to clear out of the circulation. But of course, in a prophylactic dose, nobody's going to die. So if you're comfortable, I would say what you're comfortable with. What do you use for atrial fibrillation? What do you use for other conditions? You have experience with those drugs. So go right ahead and use that drug in lieu of low molecular weight heparin, because it's important to protect the patient for the period of time that they are at risk.
Thank you very much.
Thank you so much to all of you. And now it's the moment to move toward the end with the last part dedicated to pelvic venous disorders. Joe, once again, thank you so much for being our guiding light. And in this moment, we will fly all the way to Georgia to introduce another giant figure, a huge expert in pelvic venous disorders in particular, is Professor Zaza Salvatore Lazzarashvili. Here is his talk, and then we will have his contribution live.
Dear friends and colleagues, the topic is very large and versatile, but due to the webinar format, I will focus only on a few aspects. Pelvic vein disorders belong to the category of diseases that need multidisciplinary management at all stages, be it diagnosis, treatment, or follow-up. I have no disclosures. A few important facts about prevalence of pelvic vein disorders. Chronic pelvic pain is estimated to account for up to 40% of all gynecological visits. Yet, an estimated 51 to 55% of women with pelvic pain remain untreated for years without receiving an accurate diagnosis. Among the causes of chronic pelvic pain, pelvic congestion syndrome accounts for 16 to 31% of all cases, which is second only to endometriosis in prevalence. Pelvic vein disorders do not have obvious specific complaints and can be manifested with symptoms characterized of gynecological, urological, gastroenterological, neurological conditions. Therefore, the multidisciplinary approach is necessary for correct management. Patients with pelvic venous disorders were mainly referred to gynecologists, from which, after the low effectiveness of the treatment, they started to go to doctors of different specialties, and at each stage, the patient received some treatment. But after a short remission, the symptoms worsened. The role of vascular doctors was less used. Technological development, especially from a diagnostic point of view, has made vascular specialists an essential member of the chronic pelvic pain management. But how effective is the work of such a team when physicians of different specialties have different approaches to specific issues of diagnosis and treatment? For example, in the latest professional version of the well-known Merck manual, dated by the December of 2020, we read that the method of choice for the treatment of pelvic congestion syndrome is hormone therapy, and only in case of its ineffectiveness, pelvic vein embolization can be considered. On the other hand, according to consensus document of International Union of Phlebology, method of choice for treatment of pelvic congestion syndrome is pelvic vein embolization, and using of hormonal therapy is limited because of high risk of osteoporosis. Another example, in the chronic pelvic pain guideline of European Association of Urology from 2015, among the causes of chronic pelvic pain are not reported pelvic vein disorders. As mentioned above, pelvic vein disorders are the second most important cause after the endometriosis. There is a difference of opinion among vascular specialists as well. In 2019, 6 different terms were used in 21 papers presented on this topic at the Congress of UIP. I asked 23 well-known experts of this field expressed his opinion, and 18 preferred the term pelvic vein disorders. I have the impression that today the situation is similar to Krylov's fable about the swan, crumb, and pike, according to which this trio decided to shift the burden, but their labor proved fruitless as each developed his efforts in the usual direction. We even want a team that will move towards one goal. What do we need today to move effectively towards the goal? Of course, creating common language and principles. Published in 2019 consensus document of International Union of Phlebology about diagnosis and treatment of pelvic congestion syndrome summarize and analyze existing knowledge about pelvic vein disorders and presented recommendations for future directions of development. This is also a very important step, publication in 2021, modern SVP classification for pelvic venous disorders, but by the International Pelvic Vein Working Group, on the basis of which it is possible to conduct multi-center standardized studies. Is it enough? Of course, no. We need disease-specified assessment tool, and work on this topic is underway. Also, it's necessary to create modern terminology with related definitions. And we must to create effective mechanisms to raise awareness of pelvic vein disorders and improve communication between different medical specialists. Thank you for attention.
I'd like to deeply thank once again Professor Lazzarashvili also for the fruitful project dedicated to pelvic venous disorders online education. Now it's another historical moment for us. We are more than honored and happy in having with us representatives of the European Board of the College of Obstetrics and Gynecology. I'd like to start thanking Professor Basil Tarlatzis who put us in contact. We have with us today Professor Campo, Professor Thanos, and Professor Verheyen from Belgium, Cyprus, and Netherlands. And we look forward for their insights on Professor Tarlatzis' talk. So I pass the mic, I guess, to Professor Campo, right?
Thank you very much, Sergio. I'm really impressed by your work. I'm so impressed by the lectures we've seen. This is the first time that the European Board College of Obstetricians and Gynecologists is involved in this session and bring so many prime speakers together with a very clear message, as it has already been said. This is really of major interest for our society and for our organization. Just to give you a brief information, the European Board is actually the platform where all the subspecialties also are gathered, like ESCO, but also the European Society of Gynecological Endoscopy for minimal invasive surgery, and which are dedicated to training, education, assessment, and validated exams. I think with the pact, as René will show you later on, is really a prime example of validated training education program. Now, I will give the word to René Verheyen, who is the oncologist and most related from his profession, but also from his interest to the venous issues, and also Professor Vasilis Thanos, who is the president of the educational program in minimal invasive surgery, will get into this matter. But I really want to stress again that it would be of enormous interest for our educational program to continue this very nice dialogue and collaboration, and hopefully to get some of those fine lectures to bring this to the European and international audience in obstetrics and gynecology. Again, thank you very much, Sergio.
It's us deeply thanking all of you for the wonderful teamwork. Hopefully just the first step of a long road. So you can stop sharing so that René, you should stop sharing. Oh, okay.
No, it's the correct one.
Okay, perfect.
But we should,
yes.
There is.
Yeah, this is a trio. This was multidisciplinary, so we have all disciplines here, and even within gynecology, Sergio, we have several disciplines, and as Rui already said, I'm the oncologist in the team, and this is very important that we have all kinds of disciplines also within obstetrics and gynecology, because we have many venous issues in our field, and I'm very honored to be here, and we are very pleased with the talk of Professor Lazzarashvili on pelvic pain disorders, which is really an issue in gynecology. But we have to stress, of course, that there are many other issues, and I'll come back to that in a moment. This is just one of the venous issues that we have to comply with. It is so important that pelvic pain disorders, pelvic vein disorders, as we now have a consensus, were put in the textbook for the training of all gynecologists in Europe. So our EPCOG textbook has a chapter on pelvic vein disorders. As a matter of fact, the society also has formulated standards of care for women's health in Europe, and also within these standards, there's one standard on what we call those days the chronic pelvic pain, which should now be renamed pelvic vein disorders. These standards are more focused on standards of care, of course, as they're called, of the process, but it stresses already also in our standards, as the review has nicely showed, that it's not only a specialized kind of care that these kind of patients need, but it should be multidisciplinary, and therefore our standards of care state that networks of all kind of disciplines are necessary in hospitals that want to treat those kind of patients. And because we have so many people that are necessary there, I would like to give the word now also to Professor Tanos, who is our minimal invasive surgeon, and he will specifically address the issue of pelvic pain disorders, after which I will come back to briefly talk about the other disorders and to wrap up our comments. Professor Tanos.
Thank you so much, René.
Thank you very much for the invitation. Thank you all. Greetings from the European Society of Gynecological Endoscopy. And indeed, gynecologists, they have to deal with pelvic pain daily. So in 15 to 30, 35% of our patients with chronic pelvic pain, at the end of the day, they are going to be diagnosed with pelvic vein diseases, especially the pelvic congestion syndrome. As you said before, and we absolutely agree, it's a multidisciplinary approach. Gynecologists, radiologists, and psychologists are all involved in the treatment of the problems. And of course, the screening starts from radiologists with ultrasound, transvaginal ultrasound, can detect most of the patients, especially when you have a disease which is big vessels, and with color Doppler we can detect it. And however, history, as is mentioned before, is of primary importance here to see whether the patient probably suffers from endometriosis. History of pelvic surgery, especially, or PID in the past, might direct you to a problem with nerve entrapment or adhesions within the pelvis causing this problem, or even big endometriomas can compress, and pressure on the vena cava can definitely contribute to this problem. So pelvic obstruction and vascular dilatation can be a result of several causes, but mainly the problem starts from the many times probably without any special cause or explanation. So laparoscopy can definitely give you the final diagnosis. And of course, once you have the diagnosis, you have to evaluate whether this can be done laparoscopically, although the gold standard of treatment is embolization, and we fully agree with the previous speakers. When you have a small problem, or many times we face this congestion syndrome when you have to do hysterectomy, and sometimes the parametria, you find a lot of dilated vessels, then the surgeon has to have good knowledge of the anatomical structures in that area, and you have to start usually from the healthy tissue and slowly approach the problem and perform the hysterectomy. Another problem is the post-traumatic AV fistulas that we face several occasions, especially after long surgeries and after a long of cauterization. History of heavy bleedings and complications during pelvic surgery might direct you to this suspicion. And of course, ultrasound and color Doppler again monitoring can give you the diagnosis and suspicion prior to your surgery. So I think I completed my 2-3 minutes as I was instructed, and thank you very much again for the invitation.
It's us deeply thanking you. Please stop sharing. Meanwhile, I like to congratulate you also for presenting. Oh, is it done? Or do you
No.
Have... no, you have
1 minute.
Okay, sorry.
1 minute, please.
No, please, all the time you want. You are like special.
No, this is the reaction actually on the review. I mean, what Professor Tanas said, and from Dr. Lazarashvili's talk, I think it's really obvious that we need a uniform nomenclature and classification amongst all our specialists, standardized and centralized care and multidisciplinary teams. That's all what both speakers already said. And what is very important, and this is what EPCOG, our umbrella organization of all obstetricians and gynecologists in Europe, would say, that there should be guidance by the societies, and these are our societies. I just wanted to mention again that it's not only pelvic pain disorders that are important for us gynecologists, but there are many other arteriovenous malformations. And obviously, as Professor Caprini also has emphasized, there are specifically the gynecologists and the obstetricians who have to deal with a lot of thromboembolic complications, not only oncologists as I am, but also particularly the obstetricians. And lymphedema, of course, is a big problem in the field of oncology, and we have several opportunities to prevent this, also surgery-wise, but I'm not going into the details. So all these issues are being discussed in a very innovative program, which is called the Project for Achieving Consensus in Training, and that is the training curriculum that has been established by EPCOG for all gynecologists and obstetricians. So through the cooperation with our organization, we can reach all the obstetricians and gynecologists in Europe. And in the future, that means that we can collaborate to make guidelines, to make training modules, educational webinars like this one, and publications, and also have these issues also being part of the primary training program for our trainees in obstetrics and gynecology. Thank you.
With this, I'd like to deeply thank you. I really like the word pact. I'd like to make a pact with you that this is just the first step of a long road together. And oh, do you still have something?
No, stop.
Okay, and that I'd like also to congratulate with you for presenting yourself as a team, because this is really our philosophy as well. So we look forward for more and more teamwork with Professor Campo, Professor Tanos, Professor Vereyen. I'd like to mention once again Professor Basil Tarlatzis, who started these connections. So we look forward for seeing you soon. Now we conclude with the 3 questions to Professor Zaza Lazarashvili from Professor Antignani, eminent figure, particularly in the pelvic venous disorder group. Luigi?
Yes, I am here. Thank you, Zaza, for your, is okay?
Yes.
You are me? Okay.
Yes.
Thank you, Zaza, for your very complete presentation. I know very well, but it's very, always complete. Only one question. I repeat the one question, but it's important for the audience. The SVP classification is very interesting, but is very complicated. And I don't think is useful for the clinical practice. What do you mean about this?
Yes. Thank you. Thank you, Pierluigi. First of all, I want to ask many thanks to our colleagues from gynecologist community who present a real plan how to move, which way to use for move together for this aim, and I hope that this short presentation that they've done now, it will be one of the basic of our future collaboration. And according to according to your question, Pierluigi, the SVP classification is the discriminative digital tool for classification of pelvic vein disorders, and the main aim of this classification was to using for the future clinical trials and publications. It's required for this aim, but also for precise communication for clinicians. To make it some simple, also the working group preparing the some application for special application for Androids. But I think that this classification is too difficult for everyday routinely use, and maybe some clinical version will be presented in nearest future.
Thank you so much, Professor Antignani, President of the International Union of Angiology. We deeply thank for having been with us today. And now we fly all the way to Costa Rica for introducing a dear friend. In this case, we couple with the nutrition world. Lorena?
Thank you. I'm pleased to introduce Dr. Annalisa Maghetti, who is a leading figure of the Italian Association of Dietology and Clinical Nutrition and dear friend of the BWIN teamwork.
And here we are with the questions, Zaza.
Good afternoon to everybody, and thank you for your kind invitation. Many compliments to Professor Lazarashvili for the complete and interesting lecture. In the multidisciplinary vision of this day, I have a question for you. In the recent Congress on pelvic venous disorder, I saw in literature that a negative correlation may exist between body mass index and pelvic congestion syndrome. Is it like this also in real world with your patient? And do you think it could be useful to have more anthropometric indices in pregnancy to prevent this syndrome? Thank you.
We thank Annalisa. Salvatore?
Yeah, it's very interesting question because the normal weight index is, I think, the mean for all doctors, all specialists. It's we must propagate this, but the latest study from United States by the Dr. Lavropoulos show that not only overweight have the negative aspects on the on pelvic vein disorders, but also the low body weight index also have the negative aspects. And the difference is that in patients who have the pelvic vein disorders with a refluxive character, they have the high body index and overweight, and the patients who have the against the pelvic vein disorders, but with the compression syndromes, the mainly of these patients have the very low body mass index. But there is no patients then or quantity of patients with normal body weight index in the patients group with pelvic venous disorders.
Thank you so much, Zav, and thank you so much, Professor Maghetti. And now we conclude with the big expert. Thanks to Oscar Bottini, who will introduce him. Oscar?
I'm glad to introduce Professor Whitley, world-renowned expert, head of the College of Phlebology. Dear Doctor.
And here is the question.
Thank you so much, Zaza, for such an excellent talk and a very nice overview of the current position of pelvic congestion. Just a couple of points. Firstly, although we all do need a standard assessment tool, and the SVP is one of the ones, it's the one that's out at the moment, the difficulty with it is it does separate as to where the problem is, and we haven't actually defined how to image best. There are still people who use diameters and don't use functional tests such as duplex. And those who use different imaging techniques sometimes lie the patient flat or sometimes have them at angles. And so all these different imaging techniques give different results, and that's going to become essential if we're going to try to classify exactly which patients are reflux, which patients are obstruction, and at what level the disease is. And of course, as I always bring up with these things, we also have to have pelvic congestion syndrome in men taken into account. At the moment, we're concentrating very much on women, but we have to remember there's a huge amount of pelvic congestion problems in men as well. And so it'd be nice to know if there's some way that we can actually bring those people into the same tool in the future. Anyway, thank you so much for your lovely presentation. And this is such an interesting area for research for the future.
Thanks so much, Professor Whiteley.
Yeah.
Zaza?
Yeah, Sergio, thank you to Mark. Very interesting questions. And the gold standard for the imaging the pelvic vein disorders is the also catheter-directed phlebography, but because it's preparing on the lying position, also the complex analysis of ultrasound assessment and the venography results, it's necessary. But previous, the careful checking of the anamnesis and also the clinical symptomatology is most important. First of all, we treat the patient, not imagings. And second question was, sorry, second question was sorry, I don't remember.
About the calibers and
about the possibility of men. Yeah, of course we know the patient with varicocele, and of course we have many patients with compression syndromes, for example, nutcracker syndromes, and it's also possible to classify it by the current and new classification.
Thank you so much again, Zaza. With this, we conclude. Thanks again for all you have been doing in this field and for all you will be doing, hopefully in the future also with the colleagues from the OBGYN ward. Now it's the grand finale, indeed, with the special dermatology representatives and vascular representative, both from Chile. Yeah. I will have to switch in Spanish now. And here their message is.
Hola, felicito a Sergio Gianesini por esta gran iniciativa mundial y la cantidad de especialistas que reunió. Un ejemplo claro de la necesidad del trabajo en conjunto es la siguiente condición. Desde el punto de vista dermoestético, la patología flebolinfática afecta principalmente las piernas del 90% de las mujeres independientes de la etnia, produciendo paniculopatía edémato-fibroesclerótica, la mal llamada celulitis. Es de suma importancia en las pacientes que lo padecen, tanto desde el punto de vista estético como funcional de las piernas, ya que en sus estadios más avanzados puede producir incluso dolor. El abordaje en estos casos debe incluir el estudio vascular de las extremidades inferiores y también el ginecológico. Esta condición debe ser abordada con procedimientos mínimamente invasivos, de manera de mejorar el drenaje venolinfático y disminuir la compresión del panículo graso sin llegar a la cirugía, que en muchos casos puede empeorar el cuadro. Muchísimas pacientes que sufren de esta condición presentan varices reticulares e insuficiencia venosa crónica que conforman un círculo vicioso que la empeora. Por esto, la importancia de contar con profesionales que comprendan el funcionamiento de los sistemas venoso y linfático de las extremidades inferiores.
And now we go for the grand finale. And it will be Professor Bottini introducing the speaker.
Thank you, Sergio. Finally, I'm going to introduce a Latin American leader and real representative of the Pan American Society, Dr. Álvaro Rego. Sergio.
Hola a todos, mi nombre es Álvaro Rego y soy cirujano vascular en Chile. Quiero agradecer a nuestro querido amigo Sergio Gianesini y a todo el comité organizador por esta fantástica iniciativa. Los seres humanos somos un gran abanico de cosas maravillosas, absolutamente imbricadas entre sí, formando un equilibrio perfecto que nos permite recorrer día a día armoniosamente nuestras existencias. Por lo anterior, es que en el enfoque de la enfermedad venosa y linfática debe ser realizado considerando las múltiples y específicas condiciones que nos enferman. El desarrollo de la medicina nos ha permitido saber más y más profundamente el entendimiento de la enfermedad, por lo que el tiempo se nos hace escaso para saber todo y de todo. Es por esta razón que la buena práctica requiere de nosotros lo mismo que la naturaleza nos da en nuestros organismos. El trabajo en conjunto de múltiples expertos en pro del mejor tratamiento para el eje central de nuestra profesión, que es, por supuesto, el bienestar y la felicidad de los pacientes, que es lo que finalmente es el premio que todos esperamos recibir.
And with this, we deeply thank Professor Orrego and Professor Stab, also because they are actually wife and husband. So I think that more than this, it cannot be a multi-specialty family and group with a nice, funny picture of the good old days taken in Guyana for a wonderful meeting of Professor Santiago from Brazil, another dear friend we are all missing. Of course, it would be wonderful since it's dinner time in Italy to gather together for the usual post-meeting social time. We understand that we still have to be patient for a little while. We will keep on being together virtually. If you want to be part of this issue about fake news, you know that we are co-working with many colleagues and top professionals all around the world. This paper reported 40% of medical websites, including fake news shared 450,000 times, for which we felt it's our responsibility to gather together, also in a multi-specialty approach, to report eventually encountered fake news, as you can do in this website. This will lead to the creation of a consensus document that will be presented during the once-in-a-lifetime opportunity of the Expo in Dubai, where I hope we will land all together in February 2022. I remind, meanwhile, that everybody can join the Vein Week initiative, becoming a developer, applying in the dedicated website. I'd like to deeply thank the ones who virtually joined us today in Italy. I look forward for the last effort of tomorrow dedicated to the social engagement. So it will be the social day with Rotary. Nothing would have been possible without the unbiased support of Alpha Sigma, Medi, and Philips, who allowed the whole Global Vein Week project, for which we deeply thank the official supporters. And we will finish with a sign of great multi-specialty and teamwork represented by the Georgia group. We indeed created a video that is telling us about the fact that it's not just where you're going, but also who you're traveling with, for which I will ask Khaled to play the video, thanking Khaled for being a great travel mate. And this in honor of Georgia and Professor Zaza Lazarashvili group. Thank you all. It has been wonderful. Have nice and safe days ahead.
Thank you.
See you tomorrow if you want. Thank you so much. Bye. Ciao.
Thank you. Thank you.